the title of this presentation is Promoting Safety, Health, and Resiliency. And I really, when I say that, it's safety, health, and resiliency for ourselves as well as safety, health, and resiliency for our patients through our therapeutic use of self, our presence, and our engagement. I have nothing to disclose. These are our objectives for today. We're going to identify the role of therapeutic use of self, including the use of presence and engagement, in affecting a patient's perception of their care and also patient outcomes. We'll discuss the current challenges to the implementation of the therapeutic use of self in psychiatric clinical settings and strategies to support the health and resiliency of nursing staff in that difficult work. And I'm going to give examples of nurse-patient interactions that utilize the therapeutic use of self and presence through engagement. And really, when I talk about those, I'll be talking about them from the literature in terms of a patient's perception or patient perceptions of our interactions with them. So Hildegard Peplau, everyone should know Hildegard Peplau, said, "There's a significant difference between taking responsibility for the care of patients and being therapeutically responsive to each patient. Every professional contact with a patient, however brief, is an opportunity to engage." And as psychiatric mental health nurses, we know we have many, many tasks that we need to complete when we're working with our patients. We're doing admissions, discharges, medication administration, education, all sorts of things that we have to do that needs to get done. And that's what I think she talks about when she says we're taking responsibility for the care of our patients. We're doing the tasks that need to be done to keep them safe. However, she reminds us that what elevates those tasks to a therapeutic and meaningful level is the recognition that each time we do one of those things, each time we're doing an admission history, each time we're doing medication administration, it's an opportunity to actually engage with the patient in a therapeutic way. So why is interpersonal engagement between the nurse and the patient such an important part of our literature? Let's take a look at the literature. So the therapeutic relationship. The patient's perception of a therapeutic, trusting, and reciprocal relationship between nurses and patients contribute to a positive perspective on the episode of care. Howard et al., and this is in the literature, and there's a bib at the end or references at the end of the slides, conducted a study in 2 public sector psychiatric hospitals in Kentucky to investigate satisfaction with inpatient services among 204 hospitalized patients. 70% indicated that they were satisfied with their care that they received during the hospitalization. What was interesting about the study was those who were satisfied, the most important aspect that contributed to their satisfaction was the quality of the staff nursing interactions that they had. The experiences they found meaningful included that staff members were available to speak with patients, that patients were comfortable speaking with staff about problems and issues, that staff members provided information that patients needed to take charge of their own illness, so that the interactions were empowering for them. And in particular, what meant the most to them is their perception that staff had their ability, had confidence in their ability to grow, to change, and to recover. Our nurses conveyed confidence in a patient's ability to grow, change, and recover reflects the affective bond that instills hope. And that's the hallmark of the therapeutic nurse-patient relationship, is the installation of hope through the therapeutic use of self. A large body of research supports the premise that a therapeutic alliance defined as the collaborative, affective bond and goal engagement agreement between patient and therapist accounts for as much as half of the outcomes in outpatient studies. And many of you probably know that a great body of literature says that what matters the most sometimes in terms of outcomes in outpatient settings is the patient's perception that there's an affective therapeutic bond between themselves and their therapist. Blaze developed a brief 10-item scale designed to measure patients' overall level of alliance to their inpatient care, which was administered to 140 patients receiving standard inpatient care early in their admission. This was done actually at Mass General Hospital. 72 patients completed the scale at the time of discharge. The results were correlated with the results from 3 different patient outcome measures. And findings were that a psychiatric inpatient therapeutic alliance can happen. If it happens, it's it's really established early. So that very first interaction with the patient, how many of you are in inpatient treatment? Yeah. So that very, first impressions count. And this study really revealed that if a therapeutic alliance will occur in an inpatient setting, it's established very early on in terms of the ability of the patient to feel that they can trust the staff. It remains relatively stable throughout the hospital course, and they found that it does exert a strong influence on the patient's final evaluation of their care. The higher the initial alliance scores were, likely to correspond with a shorter, less problematic hospital course. So this was one of the first studies that really correlated the development of a therapeutic alliance with a shorter, less problematic, meaning less potential for violence, less potential for seclusion or restraint or other things during their hospital course, and greater satisfaction. So in terms of safety, from a safety perspective, Buford et al. Utilized a standard alliance scale to measure the patient's level of active collaboration in the treatment process with 328 patients in a hospitalized and locked psychiatric inpatient units. That was a number of units. And the relationship between the development of a therapeutic alliance and episodes of aggression. Scores were correlated with an acute psychiatric symptom scale and ratings on the aggression scale by nurses. They found that patients who had a poor therapeutic alliance at the time of admission were significantly more likely to display violent behavior during hospitalization. So that again correlates the use of therapeutic engagement and therapeutic alliance with increasing the safety of a setting. So what we know is, in acute psychiatric settings, persons experiencing an acute episode of mental illness require 24/7 nursing care to maintain their safety and the safety of others while supporting their journey back to health. However, Mullen in 2009 conducted a literature search of journal articles on acute psychiatric nursing care, and he found concerns raised in the literature regarding the declining amount of time that meaningful face-to-face interaction between nurses and patients occur, and a trend towards an observation and culture to maintain safety. In working with patients with acute safety risks due to their symptoms, psychiatric nurses can resort to a defensive mode of practice sometimes, where time is spent reacting to situations rather than being proactive in planning individualized nursing interventions. And we know that there's a lot of reasons for that. There's a lot of, certainly patients, the threshold for admission gets higher and higher, so the safety risks are higher and higher. Sometimes staffing issues are in the way, and we're all very concerned about maintaining our patients' safety, but the concern that's developing in the literature is that we've kind of had to move towards an observation and monitoring culture which can get in the way of taking care of patients, and I'll talk more about what those challenges are. Over time, a risk and safety can contribute to nurses becoming psychologically withdrawn from patient interactions to protect oneself from burnout or as a result of burnout. The trends towards relying on data obtained by observing and monitoring patients can minimize the ongoing need to engage, assess, and interact to improve the patient's health status, as nurses may believe they have all the data they need. And this really resonated for me. I know we have Q15-minute checks. It's really important part of our safety monitoring on our inpatient services, but this really kind of resonated for me that, gee, we think doing that, we have all the information we need about the patient. However, what we do know is that knowing where the patient is and what the patient is doing is actually different than knowing the patient. Knowing of the patient is a well-established core value in nursing practice. Knowing the patient is different than knowing about the patient. Knowing about the patient relies on information gathered from observations, from chart reviews, from treatment planning, from nursing report, all of those sorts of things. And knowing about the patient is important. However, while it seems that there may be never enough time just to sit with the patient to hear their perspective, recall that Peplau reminds us that every interaction, even if that interaction is about observation and monitoring, checking them off on the rounds board, is an opportunity or completing the admission history, administering medications, etc., is the opportunity to engage with that patient in a meaningful way as an opportunity to listen versus instruct. So it's different from knowing about the patient. It occurs through interactions that the patient seeks to understand that seek to understand the patient's perspective on their experience of their illness. And it involves selecting interventions based on an understanding of the meaning that patient attaches to situations versus based on manifested behaviors. You'll be getting more, I think, in terms of safety, but this also really resonated with me. We all know that some interventions work with some patients and they don't work with other patients. And the reason why they work with some patients and not with other patients is the interventions that really work with a patient are the ones that emanate from your understanding of what does this situation mean for this particular patient. This situation has a different, just like each one of us will perceive this experience today very differently, it's our understanding of how this patient's understanding this situation that will guide our interventions. And in order to do that, we have to know the patient. So what gets in the way of knowing the patient? Well, we're human. That's the main thing. We're as human as our patients are. We're all on this, I always say we're all on a continuum. You know, when we're human first, and we work in stressful environments. And there's a lot of stress that we experience in our stressful environments. Could be hostile, threatening behaviors on the part of patients who are psychotic, delusional, or stressed themselves, and that's the only coping mechanisms that they know in the moment. You feel vigilant that you have to, vigilance in terms of maintaining the safety of our patients, maybe working with highly suicidal patients, and you're always afraid of what might happen. You may have a patient who does multiple self-harming behaviors, and you're really anxious about maintaining their safety. On the administrative side, you can have a perceived lack of control that you can control what's going on. I mean, how many of you can say you can't take an admission because it's too acute? Or there's a sick call and you're not sure how you're going to be able to fill the sick call. Or you may have a disagreement with your colleagues around how to really take care of this patient in the right way. You know, you have one set of colleagues believes we should be doing this and another one, and so there's tension in the work group. And that stress, that tension creates stress. So I'm just as a very brief review of what happens neurobiologically before we even have a single thought when we're stressed. So you hear a chair being thrown at the end of the hallway. And the first thing that happens is your thalamus hears the sound. It's not even a thought at this point. Hears a sound and says, uh-oh, something's happening. There's an intense sensation. And it immediately sends a message to the amygdala that says, prepare for threat. And it also sends a message to the hippocampus saying, do we have any other experiences associated with that sound? So what can happen is, and this is a good thing, actually, this is why we're all still alive, is that our body prepares us to protect ourselves as soon as we hear something. But right now, we're just a neurobiologically activated human being reacting to a sound that we just heard, and our hippocampus says, oh yeah, I know that sound. That happened 2 weeks ago, and it was a really bad situation. So what happens is our bodies become physically, mentally, and emotionally ready for action. Our muscles tense, our heart rate increases, we get a dry mouth. The dry mouth is to prevent aspiration. Actually, I learned that from a physiologist. But we posture. This is before we even have a cognitive thought about it. We're posturing either, if we're fight responders, we're posturing looking like we're ready to do battle, or if we're flight responders, we're like trying to sink into the woodwork. Remember this important med I have to give somewhere else. But these are, again, because we're human. Mentally, we become vigilant because our bodies are saying, there's danger out there. Where is it? Stay vigilant, but also tunnel vision. Just when you really need to step back and be able to look at the whole picture and say, okay, what do we have in terms of resources? Who could it be? What do we know about this patient? How do we know this patient? What are we going to do to be able to help that patient? Instead, we get tunnel vision. What are we going to do to control the situation? Because that's what our body's telling us to do. And we get preoccupied with that. And we have decreased self-awareness. For those of us who are fight responders, we tend to get angry. for those of us, or feel that way. For those of us who are flight responders, tend to feel fear. If we're always activated this way, after a while we just feel depleted and we have an increased sense of isolation. I'm just going to ask, how many of you remember the television show Lost in Space? Oh, good. So the way the prototype for this is, if you remember in Lost in Space, I love being with an audience who still remembers that, by the way. Remember the little robot that would go out? Yes. And the robot, this was a family that was marooned on a planet, obviously before NASA, because they were there for years, from what I can tell. And they had a little robot, and the robot would travel around the planet. And when the robot sensed something, the robot's arms would go up and down, and his little head would go around, and smoke would come out of his little head, and he'd say, "Danger, danger, Will Robinson," and everybody would run into the spaceship, and they'd put up the force field, and they'd look out like this to see where the danger was. That, I thought, was always a graphic description of exactly what happens to us when something occurs that gets us going. So we use the self-awareness model where I am to help us understand that it's okay to be human. Just recognize it. Understand that what you're right now is you're neurobiologically activated, and if you act just out of that, how does a patient feel when they see you coming out with your heart racing and your posturing and you're vigilant, and it doesn't feel so good. So some of us are fight responders, some of us are flight responders. We're not always just one way or the other. Different situations will emote it. The whole idea is be aware that you've just been activated and what that could look like. So this is what it could look like to a patient. We talked about if this keeps going on after a while. Remember, we talked about nursing staff can become disengaged just because you're feeling a little burnt out about all of this activation that's going on. So Tybolt did a study, this comes out of Dalhousie University in Nova Scotia, where they interviewed 6 very acutely ill psychiatric patients with schizophrenia or bipolar disorder on an inpatient unit, and they asked very open-ended questions to those patients about what it was like to be an inpatient on an inpatient unit. And like most of the literature I've looked at, what was striking is what the patients talked about was their interactions with the nursing staff. Even though they were like, what was the best thing that happened to you here? What was the worst thing? When did you feel the worst? They wanted to talk about it. So here's a quote from that. Approaching the desk, the tone of voice that would be given to was like blanketing everything. And not just about if you had a huge concern, but just in general. So sometimes you feel like you aren't being seen. The nurse doesn't have a particular expression. Not really hearing or seeing what's being said. What was his reaction? Let's take a pill. He wasn't working off the issue. It was kind of like a blank page. And it made me think that when the patient went to the desk, this is what they saw. Somebody who's well protected. This is a version of running into the spaceship and looking out. And again, this is not about blame. This is about understanding that this is what can happen when we work in very stressful environments and we don't take care of ourselves or each other. Here's another quote. I have a feeling that technically the nurse's job would be there in case of emergency or to dispense medication. They are not by any means supposed to talk to us. Like, if you don't want to talk, they don't have to talk. I found that you would have to chase them around, and we've all seen that. It was the special ones who would talk. And it made me think of this. So that chair gets thrown, and everybody runs out, and everybody takes care of the situation, and then what happens? Everybody goes back to the nurse's station and tries to decompress. So what have we told the patients about the way to get our attention? What have we communicated to them? Yeah. And really, they're just trying to get our attention. And we're just really working in very, very busy, difficult environments. But this is the patient's perception. So something for us to think about. So we've started using, where I am, integrated some ideas from critical stress management to help in daily life in our clinical settings as a way of taking care of ourselves. Critical stress management actually came out of the work from Everly and Mitchell back in the 80s or 80s, working with emergency responders. It started in New York City and then spread to disasters. And we've adapted some of those principles. So to help us respond versus react. And that's really kind of the theme here. How the first part, the self-awareness piece, was about we're neurobiologically reacting. How do we get ourselves to a place where we can respond instead of react, which will support the ability to therapeutically engage? So the first step is to recognize and understand our own stress reactions as human neurobiological activation to fight or flee. So we just did the pre-education about that to understand that. Then to use coping strategies to reduce the intensity of the stress reaction and to promote a therapeutic engaged response. And then we implement components of the critical stress management principles into daily practice, and I'll talk more about that right now. So remember that thalamus has gotten the amygdala and the hippocampus all activated and reacting. But the thalamus does another thing. It actually then sends a message to the prefrontal cortex, and thank God our brain is now going to start cognitively processing the information. And the prefrontal cortex's job is to say, hold on a minute, let's get more information, let's filter out the intensity so we don't overreact. And this is really understood in terms of understanding working with trauma victims, because if people don't have the opportunity to engage their prefrontal cortex every time they experience a traumatic event, or the hippocampus says what I just heard is associated with something really bad, the path to the amygdala gets worn such that it goes quickly to there and it never goes to the prefrontal cortex. So working with trauma is about how do we get ourselves to start talking about what we're thinking about right now, and when we start talking about it, we're starting to engage our prefrontal cortex. So demobilization is one of the strategies from critical stress management that we use. And that demobilization is, remember when we saw those in that slide, we saw all of the folks running out to put out the fire, which is, I think, a nice thing. And everybody runs back in. We're asking, we now ask our staff to spend 5 minutes processing what just happened, talking about it. Acknowledge the stressful situation that they just experienced. Acknowledge that some of us are experiencing a fight reaction, some of us are experiencing a flight reaction. We normalize the neurobiological activation we just had. Acknowledge that these are human reactions will get in the way of establishing the level of engagement we need with each other and our patients to move beyond a crisis mode. And then acknowledge that just as activated as we are about what just happened out there, what about the other patients who witnessed it? What's going on out there? Acknowledge that patients are experiencing similar human reactions and need us now to go back and engage in a responsive, engaged manner versus a reactive, disengaging manner to promote safety and to promote resiliency. So the opportunity to talk, for though you can't spend more than 5 minutes, and you'd be surprised, maybe you wouldn't, that every people say, we don't have time to do that because, you know, the unit is so acute, we just got to get right back out there. Well, if you're going to get right back out there looking like somebody really stressed out, that's not going to necessarily be reassuring. So spending those 5 minutes to say, wow, that was scary. What a great job everybody did. How's everybody? Did anybody get hurt? Is everybody okay? And decompress the reactivity. So the other thing, I don't have a slide on that right now, but the other thing that we ask to do is at the end of the shift for people to spend a little bit more time, 10, 15 minutes, processing again, because usually when a situation like that happens in a clinical setting, you know, it's a busy shift, and you want to be able to process it and do more talking about it and support each other in a positive way and support the things that happened well in a positive way versus when the evening shift comes on, for those of you in the inpatient unit saying, good luck with that, I'm out of here. What have you just done? What happens to them? Oh, you know, and their amygdala gets activated. So to try to acknowledge that these are stressful situations, we're humans in them, but how do we engage our stuff? So now I'm going to talk about therapeutic use of self and presence. And this comes from the literature about patients' perceptions of what is important to them when they're at their most vulnerable and critically ill. or any time in any kind of interaction from a mental health point of view. Relating through the ordinary, the ability of nurses to identify opportunities to interact with patients in meaningful ways without appearing to be assessing, history taking, or delivering a designated therapy. So that really actually connects right back to what Hildegard Peplau said. Each of those things are an activity, but each of those activities is an opportunity to interact in a way. So there's a big difference between, are you hearing voices, what are they saying, are you, the kinds of questions we ask, and saying, what's happening for you today? I noticed you look a little bit better. How's that? What's going on with you? Another one was empathy under duress. The patient's illness kind of seeps into you. So the situation becomes one in which you sit and listen to a lot of feelings, which is presence. Remaining physically near and emotionally in touch with a patient who is in acute psychiatric distress. Sometimes not saying anything, sometimes just being there and listening. Knowing the patient was another theme from the literature, drawing on intellectual understandings, including the unconscious mechanisms underpinning behaviors that are socially unacceptable when viewed superficially. I like that. So many of the behaviors we witness are considered socially unacceptable. As psychiatric mental health nurses, we understand what's underpinning that behavior. We understand that history. And it's drawing on that and our knowing the patient that allows us to intervene appropriately without saying, that's inappropriate, you need to go back to your room. Asking the patient, recognizing that patients are experts on their own history, preferences, and problems. They're the experts. We can learn from them about what it's like to experience their illness and what works for them and what does not. So here's another quote from that literature from Tybalt. The patients would watch television, and the nurses would sometimes come and watch too. Actually, I took out the part that for this one it was a reality TV show. I have no idea what they were watching, but I always say to my staff, if I come on the unit and I see you watching television with the patients, I know you're working. Don't worry, I know you're working. But would sometimes come and watch too, and there would be interaction. But in that situation, I know it took down somebody else's wall in the sense of being able to talk openly about being schizophrenic. There was a certain nurse who was sitting next to that patient and me, and we somehow got into the conversation, like he opened up. And I think there's always a sense of community and relief because there's still a lot of stigma. There's a lot of mystery there. And I think that interaction at that special level made all the difference in the world because you didn't feel there was so much inquiry. And that's another theme that I saw in the literature is that patients know we ask them a lot of questions, and they get that we have to ask them a lot of questions because we have to know about them to keep them safe. But they also what matters the most is the interactions that are not just about asking questions. And in this case, a normal conversation that could be about what it's like to be schizophrenic or what it's like to have diabetes or what it's like to have cancer, same thing. So psychiatric mental health nursing. So psychiatric mental health nursing involves, the work that we're talking about here is how to promote your health, your resiliency, and your safety such that you can promote the health, resiliency, and safety of your patients. Psychiatric mental health nursing requires active engagement on the part of us with each other, with our interdisciplinary teams, with the patients, with their significant others, with their families. And it requires connecting engagements. So you can see in this circle, it's a little pale, but there's the patient moving through their situation. There's the staff moving through our situation. Every time we engage, we can turn that bigger cog that's empowerment and motivation if we take care of ourselves and really pay attention to this. So each time we engage, we empower and motivate ourselves and them.